Hello, my name is Bryan Petrow, and I'm here to give a topic presentation on chronic pancreatitis. I am a recent graduate of the Albany College of Pharmacy and Health Sciences, holding my doctorate in pharmacy, and this presentation will cover the causes, presentation, signs and symptoms, diagnosis, treatment, and last of all, special emphasis on drug-induced pancreatitis. Our investigation begins with a case study, and I will refer back to it repeatedly throughout the course of the presentation. AB is a gentleman who presents with severe abdominal pain radiating from his upper right quadrant to his back. He has a past medical history of recurrent pancreatitis, cholecystectomy, type 2 diabetes, and hypertension. His social history is significant for regular smoking, yet he denies alcohol use. While appraising the causes of pancreatitis, it's useful to remember an acronym. The one I use is TICAR-O. T stands for toxic metabolic, I for idiopathic, G genetic, A autoimmune, R recurrent, and lastly O for obstructive. Toxic metabolic disorders suggest a toxin is introduced. Alcohol is a prime example. It was once thought to be the only cause of pancreatitis. Now we know a little bit better. A few other toxic metabolic causes include scorpion stings and smoking. Idiopathic, on the other hand, is less defined. We can't attribute it to any causes that we can readily identify or predicting factors, and it surprisingly accounts for quite a bit of cases. 15 to 20% are idiopathic. Genetic cases include cystic fibrosis. There's a few other rare ones infecting the liver that we have to watch out for. Autoimmune suggests that the body is producing antibodies attacking the pancreas and its ducts. Type 1 diabetes is a prime example. Other IgG-mediated responses can arise, so we want to look at IgG4 serotypes in the lab. Recurrent suggests that the pancreatitis has happened before, but not frequently enough for it to be chronic. Obstructive suggests that there is something in the way of the ducts and sphincter of Oddi preventing the flow of juices from the pancreas to the intestines, or from the liver and the gallbladder to the intestines. So gallstones is a prime example. Other calcification is an example, and stenosis. Cancer can even cause obstructive issues, and drugs will also do this. So it tends to be collectively the most common. Distinguishing between acute and chronic pancreatitis reflects more than the mere time to onset of the first episode. Although chronic pancreatitis will result from recurrent episodes totaling 10 or more years as a rule of thumb, there are unique physiological differences between the two disease states that should be looked at. Chronic disease state reflects inflammation of the nerves and ducts, and through the inflammation, certain cells will grow and enlarge. Among these are nerve cells, and when these nerve cells enlarge, and particularly the ones that are nociceptive, this will increase the level of pain one expects. And through repeated insults, the higher order cognitive faculties will begin to internalize some of this pain. One may even become depressed in relationship to their pain, and yet this depression is not the source of their issue. The issue is the pain resulting from repeated insults to the pancreas. That's not to say we treat them differently. We tend to use gabapentinoids and TCAs and SSRIs in a similar fashion. Well, when we're looking at the acute causes. Elevated lipase is the most telltale marker. We also see intra-abdominal pus. Conjugated bilirubin levels, this is the telltale marker for obstructive issues in particular. Fibrotic lesions showing a progressive loss of endocrine and exocrine function within the pancreas, and plumbing issues and wiring issues alike. That's not to say that wiring issues always arise from plumbing issues or vice versa. Sometimes you can have wiring issues that arise spontaneously, like in the case of cancer, that would pinch the nerves, and yet it doesn't really reflect the pancreas's role as an exocrine organ. And another case, we can have an obstruction to the plumbing and yet no pain whatsoever. This does happen in about 10% of cases. It's very strange indeed, but yet it is a possibility that clinicians should be aware of. Piggybacking on our previous discussion of pancreatitis and pain, it's useful to understand the relative proximity between the celiac plexus, a major sympathetic and nosocomial neuronal superhighway, and the pancreas. When pancreas swells, it can physically pinch the celiac plexus and related blood vessels, and in more extreme cases, when the proenzymes of the pancreas become backed up, they will activate and chew through the pancreatic tissues, enter the vasculature, and eventually burn a hole through some of the neuronal fibers. This causes intense pain and intense inflammation and has a high chance of affecting the cognitive faculties after long-term insults. Apart from pain, there are other curious signs and symptoms of pancreatitis. The chronic disease state tends to be associated with liver inflammation and or exocrine duct occlusion. One may cause the other in this situation. In terms of the occlusion, we have to look at calcium levels. If calcium increases to over 11 milligrams per deciliter, that is an indication that stones are highly prevalent. And in this regard, when liver insults are regular, serum albumin will be low, so it's important to correct for your calcium. Acute flare-ups will resolve spontaneously, or they tend to anyway, after 6 to 10 years, but that only really suggests that the pain has become constant and highly emotional in nature, owing to the chronic disease state. About 3 to 13% of patients who experience acute pancreatitis will develop chronic pancreatitis. And when it comes to chronic pancreatitis, both endocrine and exocrine disorders, diabetes and malabsorption, both of them tend to last a lifetime. Returning to the patient case, AB does have a few factors that need to be addressed. His upper right quadrant inflammation is one of them, and the delocalization of pain radiating to his back reflects the celiac plexus and all the tissues it innervates. But when we looked at some objective measures, it's a little bit less clear. The CT scan was unconclusive, and the ultrasound only showed an enlargement of the liver similar to what we would have just noted in the physical exam, but the lipase level is high, indicating that the progression has transitioned to the point when the pancreatic juices are escaping the pancreas and causing real irritation. Cytokines are being produced, amping up the blood pressure. Oftentimes blood pressure falls with cytokines, but in this case of the pain being so acute, blood pressure rises in this particular situation, unlike sepsis. It also helps to understand that this is the 8th time the patient was treated for pancreatitis in 20 years. Based on our timetable, safe to say that the patient is on his way to developing the chronic disease state. He likely has it by now. As clinicians, we're often called on to explain what the drug-induced causes of pancreatitis might be. I like to think of an acronym to help me remember. Bad shave is what I use. Bile acid sequestrants, ACE inhibitors, diuretics, statins, heart therapy, azathioprine, valproic acid, and estrogens can all cause it. Bile acid sequestrants work by increasing triglycerides and therefore might be implicated in liver inflammation. ACE inhibitors are associated with the inhibition of breakdown of bradykinin, and when that occurs, inflammation and will cause duct occlusion in a similar mechanism to what we can expect to angioedema occurring. The relative risk here is 1.5. Diuretics have been shown as a class to be 1.7, both of which are statistically significant. However, when we think about the fact that only 1 to 2% of those people with acute pancreatitis get their pancreatitis from a drug interaction or a drug, it might not be clinically meaningful, but it's definitely worth informing the clinicians of in the treatment team. Statins are another one. Statins can inhibit liver enzymes, they can cause myalgias and rhabdomyolysis, all of which can cause the disease. Heart therapy can also cause the disease by inhibition of CYP enzymes, but also we have to also think about lamivudine because it will cause hepatotoxic effects, which seem to place it at a higher incidence than, say, ritonavir, which also inhibits CYP3A4, or does so fairly well, I should say. Azathioprine causes pancreatitis. However, it's more so to do with the Crohn's disease that azathioprine treats. Azathioprine is toxic metabolic, will cause liver inflammation. However, because Crohn's disease is already associated with inflammation, it's likely that the azathioprine will increase motility and cause bad reactions attributed to the bowel disease. Valproic acid tends to have the longest track record of causing pancreatitis. It was identified in the 60s, and by the year 2000 it had a black box warning for pancreatitis. It's even caused death in certain individuals, and this is a little bit interesting because unlike some of these other agents, we do not want to decrease our dose of valproic acid. You always want to switch it to a different agent because it's not dose-dependent interaction here. Lastly, estrogens can cause pancreatitis. Thromboembolic disorders and steroid effects on liver are both thought to be causes here, and it's also important to note that other steroids will cause a pancreatitis but at lower incidence than estrogens. I have presented in front of you the medication list for AB. It includes several agents, and I'd like you to look at it briefly and let me know what the possible causative agents might be. Let's see how you did. By my assessment, enalapril, furosemide, and hydrochlorothiazide are most so associated with pancreatitis based on all his medications. Panel right, you can see Mr. Trump giving a bad shave to Mr. McMahon in certain WWE episode. Definitely a bad shave indeed for Mr. McMahon. All joking aside, let's look at the diagnosis of pancreatitis. It's important to take an appropriate history, not to be so presumptive on what might be causing the disease, but to look for signs like previous gallstones or diabetes that could be indicating a pancreatitis attack in the future. Lipase should be drawn. That's an important lab, highly diagnostic, as is CT scan. That's the number one imaging technique we should be applying. It can detect calcium deposits and distended ducts. Although it takes a little bit more planning involved, MRIs can be used and it can detect similar sorts of complications resulting in pancreatitis. Ultrasounds are not good enough to diagnose pancreatitis on its own, but they can still be highly informative. They can rule out other diseases such as pancreatic cancer that might look like pancreatitis at first but need to be treated entirely differently. But the low sensitivity really makes it not the best, even though it's less invasive than the others. Secretin tests tend to be fairly infrequently used, only for attacks that evade the other techniques. The basic principle is that the patient is given secretin, and then a tube is placed in the intestines, and that tube will collect bicarb secretions, and based on the bicarbonate level, it's possible for clinicians to detect whether an obstruction is at place or how much deterioration of the exocrine function has resulted from previous attacks. Consider alternative diseases and complications when we look at a diagnostic workup. Don't be too presumptive. It could be something that we're not really considering. It could be something else. All important factors to consider. The CT scan before you shows calcium deposits. This is one of the benefits of using this particular technique. They are centered right around the gallbladder. From what I can tell, this patient has a gallstone. It can be done this easily, this simply, and from here we can look towards treatment solutions. The surgical techniques are as follows. Extracorporeal shockwave lithography can be used to break up gallstones with high-frequency sound waves. Also, the pus-down procedure can be performed, in which an incision is made within the gallbladder and the stones removed. Full gallbladder removal can be performed, preventing new stones from arising. It is used routinely. In the case of AB, he had that procedure done. We would have seen that in his history and physical. That's why it's important to do these workups. Nerve block can also be used, and nerve block will reduce the pain post-surgery. Liposomal bupivacaine and methylprednisolone, when used together, afford the patient with several days' worth of pain-free living. However, it's not really all that great for non-surgical procedures. It's not even FDA approved for non-surgical procedures. So definitely be cautious about liberal prescribing of nerve block. Eventual resection of the pancreas may be necessary by way of Whipple procedure. And please note that scope techniques may be useful for surgery, but they should not be performed for exploratory reasons. We have other imaging techniques for that. The Whipple procedure is quite elaborate and used for many end-stage pancreatitis issues, including pancreatic cancer. The basic idea is that the gallbladder, part of the duodenum, and frontal portion of the pancreas is all removed and stitched back together such that the pancreas is downstream of the duodenum and the stomach, as we see in the diagram Appropriate pharmacotherapy can make a big difference in a patient's quality of life. There are two main solutions: correct the underlying disease or provide analgesic support. Oftentimes the former can't be done, so we have to jump to the latter. To this effect, 50% of patients with chronic pancreatitis are currently taking opiate analgesics. I'd like to see the statistic decline, but as it turns out, our alternatives are not well developed. SSRIs, SNRIs, tricyclics, tramadol, and gabapentinoids tend to be used as alternatives, and among these, only pregabalin has a randomized, double-blind, placebo-controlled trial associated supporting its use. Autoimmune pancreatitis can be treated with corticosteroids. Prednisone 30 milligrams by mouth every day tends to be most common. And also antioxidants have randomized controlled trials, two of them. Adding exocrine support has also been shown to decrease pain associated with the disease state, because when we give it, we not only correct the underlying malabsorption, but we also trigger the pancreas to stop producing as much enzymes of its own. These enzymes can and often do contribute to increased irritation of the pancreas and neuronal damage. It's always important to take the patient off the offending agent. However, oftentimes there isn't an offending agent, so we're left to look at pain control, which is not what we would like to see, but it's the reality of the clinical picture. Let's examine for a moment our placebo-controlled trial, pinning pregabalin with placebo. Researchers Olesen et al. Wrote the study. It was published in Gastroenterology in 2011, and the trial took place over 3 weeks. 61 patients enrolled, and the study analysis was done intent to treat. The intervention was either placebo or 75 milligrams of pregabalin. These were given by mouth twice a day, and in the pregabalin group, dose increases occurred. The dose increased to 150 milligrams after 3 days, and it tolerated 300 milligrams after 1 week. The primary outcome measure was a reduction in a 10-point pain scale called the VAS scale, and after 3 weeks, 0.5-point reduction was observed between the groups, but more substantially, in my opinion, the daily morphine equivalence burden in the pregabalin group decreased, and this decrease was on the order of 30 milligrams compared to 4 milligrams in the control group. So I'd say that this is the real sticking point of the trial, despite the primary outcome measure also being, well, at least statistically significant. The graph at hand was lifted from Olesen et al.'s journal article. The VAS score was plotted against time. The black line denotes the pregabalin group, whereas the dotted line denotes placebo. By week 3, there is not a real difference between the two groups. However, the intent to treat nature does lead me to believe that their trial results are significant, and this significance derives from a morphine dose equivalent reduction in the pregabalin group compared to placebo. Returning to the patient case, AB's CT scan came back negative for pancreatic stones and calcification. Ultrasound did show inflammation, although this was not entirely unexpected. He was placed on an MPO regimen and then given meperidine in the hospital for acute pain. He was subsequently discharged when lipase levels normalized. After several years, AB returns to the clinic. His medications have substantially changed. Can you detect any problematic fits? Are there any that seem to be protective? Based on the bad shave acronym, atorvastatin is more likely than the other options to be causing him future harm. Atorvastatin is a statin drug. It can cause rhabdomyolysis, myalgias, and CYP inhibition, and these can put a strain on the liver and vasculature. When it comes to corrective medications, amlodipine should be looked at in greater detail, especially for those who have obstructive comorbidities. To the right panel, we have bad shave, sinister friend, fat shave. My conclusions about calcium channel blockers as restorative owes itself to this here trial written by TICAR-O et al. Placebo was tested against nifedipine in patients who had a sphincter of Oddi abnormality, many of which had also pancreatitis. Based on the outcomes, there was fewer episodes of pain, fewer oral analgesic tablets, fewer emergency room visits, and decreased pain score comparing nifedipine to placebo. And all these cases, the results were statistically significant based on P of 0.05. However, this trial is a little bit blind to clinical significance. It should be taken with a grain of salt, but does point to a benefit here for those with duct abnormalities contributing to the pancreatitis. Several clinical pearls spring to mind as I bring my presentation in for a landing. If possible, we should treat the root cause of disease before it becomes chronic, and that really holds true for pancreatitis as well. As clinicians, diagnose the disease by ruling out other alternatives so that we are very sure what we are dealing with is the disease state of chronic pancreatitis and not a cancer or other abnormality involved with electrolytes or extravagation or other such issues that might come into play. 50% of patients, like AB, have been prescribed an opiate or on opiates and for pain associated with a chronic pancreatitis. It's good to try to add in alternatives to make sure that that number is reduced as low as we feasibly can without compromising patient quality of life. But on the other side of the coin, we also have to remember not to oversell the alternatives because less data exists for them. To this effect, only pancreatic enzymes, octreotide, antioxidants, and pregabalin have randomized data supporting their use in chronic pancreatitis. Lifestyle modifications and lipid lowering are cornerstones of therapy and should be and will be for the foreseeable future. My references appear before you. If you have any questions, feel free to email me. My email is bryan.petrow@acphs.edu.